Hi, everyone. I'm Ivy Elkins, one of the co-founders of the EGFR Resistors, along with Jill Feldman. We're here with Dr. Helena Yu and Dr. Joseph Chan today. Welcome, Dr. Yu and Dr. Chan. Thanks so much for taking the time to participate in our EGFR Resistors webinar series today on progression and resistance, which is sponsored by Blueprint Medicine. Today, we'll be discussing the topic, what is histological transformation and can it be treated? We've gotten a lot of fantastic questions from our EGFR Resistors Facebook group, and many of these will be woven into our conversation. Other questions that aren't covered in our discussions today, we'll cover in the wrap-up at the very end. So let's get started. Dr. Yu and Dr. Chan, please tell our group a little bit about yourselves, where you practice and do research, and how you're involved with EGFR positive non-small cell lung cancer.
Thanks, Ivy. Hi, everyone. I'm so happy to be here. I am lucky to have worked with Jill and Ivy on a few things in the past, but EGFR mutant lung cancer is my work passion. I work as a medical oncologist at Memorial Sloan Kettering. I've been there for more than 10 years now, and I see patients that have lung cancer, and my research is focused on EGFR mutant lung cancer. So I run all of our clinical trials at MSK that are focused on EGFR mutant lung cancer. I live in Manhattan, and I have 2 kids too.
Yeah, thanks so much for including me too. So my name is Joseph Chan. I'm a thoracic oncology fellow at Memorial Sloan Kettering as well. And I also do research, particularly in histological transformation, and trying to understand the molecular mechanisms that are driving it using computational biology, or otherwise known as artificial intelligence. But yeah, happy to be here.
Thank you both for introducing yourself. Dr. Chan, you were a little modest, and I'd like to remind everybody that you won the grand prize at our EGFR Resistors Summit last month. So congratulations, and thank you both again for all of your hard work. So let's start. Dr. Yu, can you give a brief background as to what it means to acquire resistance to targeted therapy and where histological transformation fits into acquired resistance?
Sure. I think it's a topic that really could stand alone as an entire topic to talk about for a long time, but I'll do my best to frame the field for us. And so if you guys can see the slides that are up, I think my first slide is really just focusing on kind of how amazing the progress has been in EGFR mutant lung cancer research. So it seems like it's been something that we've known about forever, but really we only first discovered the EGFR mutation about 15 years ago. And so through that period, we've developed different drugs and come to understand how best to treat EGFR mutant lung cancer, and how we treat EGFR mutant lung cancer today is actually even different from 2 or 3 years ago. So I think that's the pace of how things are moving. When we talk about 2020 or soon to be 2021, most of us, particularly in the US, utilize Osimertinib as our first line EGFR inhibitor of choice. And that's really based on the FLORA study, which many of you guys are probably aware of, that compared Osimertinib to either erlotinib or gefitinib as earlier first generation EGFR inhibitors that were previously the standard of care. And those studies really demonstrated that time on treatment, what we call progression-free survival, as well as overall survival, so from the time of diagnosis of metastatic lung cancer to death, was significantly better with the use of Osimertinib compared to these earlier generation TKIs. There's a lot of research now looking into how can we improve upon Osimertinib first-line treatment. So there are different combination studies that are being looked at. So we look forward to moving the bar even higher and helping patients last on this first treatment for longer. But I think what is universal, whether we're talking about treatment with erlotinib or osimertinib, is that at some point the cancer finds a way around the treatment and begins to grow. One of the things that we really look for is something genetic that explains why this resistance happens. We don't always find that, but that's something that we're certainly looking for, because the more that we can kind of hone in on somebody's individual cancer and figure out what's changed in that cancer, it helps us personalize treatment for each patient, which I think is important. One of the next slide to look at is really just kind of a picture of how things have changed with osimertinib as first-line treatment. And maybe not everyone that's listening to the webinar has gotten osimertinib as first-line treatment. So there are earlier generation inhibitors that are approved when patients have, or when lung cancers become resistant to those inhibitors. Those earlier generation inhibitors, they usually develop EGFR T790M. That mutation in EGFR prevents the inhibitors from binding onto EGFR, or at least decreases the affinity for those drugs and leads to resistance. And then osimertinib was initially developed as a T790M inhibitor, so initially approved in the later line setting, but then because of that FLORA study has moved up to the first line setting. And one of the questions is the resistance kind of spectrum to osimertinib different than the resistance spectrum to other EGFR inhibitors? So the next slide is a figure from a paper that we and others published at MSK this past year that basically is looking at mechanisms of resistance to osimertinib, whether given in the later line setting or the first line setting as first line treatment. One of the things that I think other of this webinar series will get into is that there is, when we think about resistance, we tend to divide it into on-target resistance and off-target resistance. When we say on-target, we're really talking about resistance that's EGFR mediated, and that usually means a mutation, a second mutation in EGFR that somehow affects the drug binding. And then the other kind of category or bucket is off-target resistance. And that means that the cancer has changed in a way that allows it to be less dependent on EGFR for growth, and that can be a second mutation in a different gene. So people might have experienced or heard of lung cancers that have developed RET fusions or ALK fusions or MET amplification. Those are all ways that the cancer can grow without being so dependent on EGFR. And then the focus of this webinar, or this discussion, is histologic transformation. And that's something that is relatively rare, but we are seeing as we do more tumor tissue biopsies. So what is small cell transformation? When we think about lung cancers, before we knew about mutations, we used to really look at the cancers under the microscope and then help, and that would basically classify different lung cancers. And so most EGFR mutant lung cancers are non-small cell lung cancers, and specifically they're adenocarcinomas. And that really just means they started from a particular gland cell that's present in the lung. And small cell lung cancers are look different under the microscope and start from a neuroendocrine cell, so a different type of cell. One way that lung cancers find a way around the EGFR inhibitor is to change histology. And so when a lung cancer changes from an adenocarcinoma to a small cell, it basically becomes less dependent on EGFR, so that allows it to grow even though the person is on an EGFR inhibitor, which should be preventing growth of the lung cancer. And I think we're going to get into it a little bit more, but when transformation occurs, then just targeting EGFR is typically no longer effective because that cancer doesn't depend on EGFR signaling for growth or spread. And so then different treatments tend to be used. And I think just because maybe no one has shown you these slides, I think it's important to sort of show the picture of things. I think if you can see on this slide, The first column is an adenocarcinoma, and that top row is just kind of the microscope view. And you can see that the adenocarcinoma cells are a little bit larger. And if you look at the second column, the small cell lung cancer stain a little bit different, and they're smaller, hence small cell versus non-small cell. And different proteins are seen with small cell lung cancer. So this shows synaptophysin, which is a protein that is present in small cell, but you can see not present in non-small cell. And Ki67 is a marker of growth. And you can see that that is very positive in the small cell, but different in the non-small cell. So when you have a biopsy and the pathologist looks, they basically can tell from looking under the microscope that this is likely small cell, and then they do special stains that help them kind of confirm that diagnosis, especially because that's more rare when something was adenocarcinoma and then becomes small cell. And then before we kind of got into questions, I wanted to go over two cases that I think can show us how different transformation can be for different people, and that it's not sort of a one-size-fits-all situation. So these are two different patients of mine. One of them is a 52-year-old woman. So she was diagnosed with EGFR mutant lung cancer back in 2018. She started on Osimertinib and had a good response with good tumor shrinkage. And then about 8 or 9 months later, she had evidence of progression, or the lung cancer showed some degree of progression. And if you look at, I hope someone has shown you CAT scans before, but basically these are cross-sectional cuts through the chest, but we're looking at the feet through to the person's head. And you can see that little arrow on the left lung is a new nodule that we saw the summer of 2019, but it was a small nodule. I wasn't expecting there to be transformation, but when we biopsied it, we did see small cell transformation on that biopsy. So this patient started on chemotherapy that's directed against small cell lung cancer. And then after she finished chemotherapy that she had a good response to, we did continue the Osimertinib. And I think one thing we might talk about later is I did suspect that she had potentially both small cell and adenocarcinoma. So we did continue the Osimertinib during her treatment. And the second case, which is the next slide, is a little bit of a different case. So this is a patient that I cared for a long time that initially presented or was diagnosed with EGFR mutant lung cancer back in 2014. She had, and because in 2014 Osimertinib didn't exist as a treatment option, she started on Erlotinib as her first treatment. And then she did well for a long time on Erlotinib, developed disease progression, and we biopsied her. She had evidence of that EGFR T790M, which is the most common reason that cancers become resistant to Erlotinib. And then she was started on Osimertinib in 2016. She responded to that for a period of time, or the cancer responded, excuse me, but then there was evidence of progression and she started on chemotherapy. And I bring this case up because it was 4 or 5 years kind of into the lung cancer disease course, where we did see for this patient, we saw on her scans, there was more significant growth. So if you can see that on the pictures here, it's the right lung, where the picture on the left was earlier, and then the picture on the right was at the time of transformation. We saw there were several lesions that grew significantly. And for her, I did have a suspicion that this might be transformation because we saw a significant growth in multiple lesions that was different than the way that the lung cancer behaved previously. And so when we biopsied her, we did see small cell transformation. So I wanted to bring up these two different cases because I think they show that sometimes small cell transformation can present differently. It doesn't always present immediately. So it can be years kind of with it, into a disease course where we see it. And sometimes it can be very subtle where, it really is only present potentially in one or a few lesions versus sometimes where we see it more significantly in terms of growth in a few places. So I want to stop there. And if there's any questions or comments about what I've said, I'm happy to answer.
So I guess I can also add my 2 cents. And with these 2 cases, it definitely shows that if there is small cell transformation, the EGFR targeted therapy alone doesn't just cut it. You got to add something additional. And in this case, with small cell lung cancer, it's oftentimes the chemotherapy that's the backbone of the therapy regimen. And while small cell lung cancer does tend to grow faster than lung adenocarcinoma, it's because of that faster growth that it has a much higher response rate to chemotherapy. And so, so I think that's also important to keep in mind.
Thank you both so much. There's a lot of talk and concern actually in our EGFR community about small cell transformation or any of the forms of histological transformation and whom it may occur to and when. So one question that we have is, are there any specific biomarkers that would predict who's likely to undergo transformation? Or are there any other clinical signs that might suggest transformation might occur or might have already occurred?
That's a great question. I think that there is never an absolute answer to that. So I think there always can be exceptions to what we typically see. In our hands, I think that what we've typically seen is that, when people get diagnosed with EGFR mutant lung cancer, we look for the EGFR mutation, but usually that's not the only mutation that we see. There's usually concurrent mutations that are present too. And I think this is an important point to tell, the people listening to this webinar, is that I think it's important not, oftentimes because we want an answer quickly, we do a fast, short, small genetic test to look for EGFR. But if that's the case, I do think it's helpful to make sure that a larger mutation panel is done. We call that a panel that typically is a next generation sequencing based mutation panel. And that usually looks for mutations in 300 plus genes. And I would say that probably almost always we do see a different mutations that can be present with the EGFR. And most commonly, we see one called P53 that's present in about 60% of EGFR mutant lung cancers. And then more rarely, we see a triple mutation of EGFR, P53, and RB. And we have seen that it's really lung cancers that have that triple mutation that have the highest risk of transformation. But even in that group, when you have EGFR, P53, and RB mutations in the lung cancer, it's probably only about 25% of them that end up transforming. So I think, but if you don't have that mutation, triple mutation, I think it is very unlikely that transformation will occur. So I think that is a genetic signature that we've been seeing that is a pretty good predictor of what cancers are at risk for transformation.
That's a great explanation. So I just want to clarify, you can find all 3 of those mutations, whether you do a tissue biopsy or a blood biopsy, correct?
That's correct. But
so
go ahead, tell me.
You're probably just about to answer it. So what about histological transformation, though? How do you find that? And how does the doctor suspect that somebody has it? And which biopsy should a person be having?
Joe, do you want to answer that one?
Sure. So I think the the gold standard way of diagnosing histological transformation is to biopsy a lesion that's suspicious, and to look at it under the microscope, as Helena showed, looking at the slides and seeing if it has that small cell appearance. Again, we can, so one of the signs that that small cell transformation may be occurring, beyond the clinical signs, you could also look at imaging. And so small cell lung cancer tends to grow faster than adenocarcinoma. So if there is a single site that is progressing under EGFR TKI therapy, whereas all the other sites remain suppressed, if it's growing rapidly and if it's lighting brightly on PET, which is a sign that it's very metabolically active, that it's growing fast, that could be a sign of small cell transformation. And then you would want to biopsy that site and then look at it under a microscope. You can also do the next generation sequencing and look for stereotypical mutations like RB1 and P53 that indicate small cell transformation as well. Whether liquid biopsies can be done to support the diagnosis of small cell transformation, it can help if you see RB1 and P53 mutations in the blood, but still you would want to be able to look at the tissue under the microscope and confirm that it's indeed small cell transformation.
Yeah, I think to add to what Joe was saying, because I do get calls from providers saying, oh, I saw RB and P53 in the blood, this patient must have transformed. But remember, it's really, even if you have those mutations, it's still the vast majority of people don't end up transforming. So I do think that doesn't tell us, that tells us that that a lung cancer is at risk for transforming, but not that transformation has occurred. So I think there really has to be a low threshold for a tumor tissue biopsy. And I think that's something that, I mean, what we're able to do on plasma is pretty amazing now with all of kind of the testing that can be done. But I think if there is a clinical suspicion, either because of exactly like what Joe said, if there was a dramatic change in the growth pattern of the cancer, or if because we detected these mutations in someone up front and we knew that the lung cancer was potentially at risk, those would be people where I would prefer to do a tumor biopsy compared to a plasma biopsy, just at a sign of progression, because I think it's something that we would only see on the tissue.
And is there any particular symptom? That's one more question somebody had about that. Is there any particular symptom a patient would have that would be different if it was histological transformation versus just progression?
I think that any symptom, short answer is no, there's nothing different about the symptoms of small cell versus non-small cell lung cancer. But I think people are very aware of their bodies. And I think if there's any change in how you feel or a change in a lung symptom like shortness of breath or cough or coughing up blood, obviously those are all things that you want to talk to your doctor about. But I think the tricky thing now, having seen this transform small cell a decent amount, is that I've seen it where I know there are some cases where for sure by looking at the scans this cancer has transformed, but I think I've been surprised a lot too where there's only been a little bit of growth. I wasn't expecting it, and I see it. So I think I think we should be thinking about it for sort of in all cases.
Had some members in our community who have had transformation, but not necessarily small cell transformation. They've had squamous cell transformation, or they've had neuroendocrine carcinoma. Are there similar biomarkers that might indicate that that's of a higher risk, or has any of that been determined yet?
That's a great question too. I think we're still trying to sort that out. I think when you see large cell, I think that some of the risk factors of that P53 and RB mutations do also come into play for kind of the spectrum of neuroendocrine cancers. And I would put small cell on one end of the spectrum and large cell kind of neuroendocrine in between. adeno, and small cell. So I think that's on the spectrum of kind of neuroendocrine transformation. So I think those risk factors tend to be similar of the RB and P53, but the squamous cell lung transformation, we're really just trying, I think are kind of first seeing it and reporting it to sort of a larger degree now. And so I think Joe in the lab and other people in the lab are really trying to sort that out. I think the challenge with, and I think one thing we didn't mention, which might clarify it a little bit, is de novo small cells. They have a clear genetic signature where all de novo small cells have that RB and P53. So that's why if you have the RB and P53, there is that risk of transformation. For de novo squamous cell lung cancers, there's no kind of set genomic signature. So it's not like we can say all squamous cell lung cancers have X mutation. So if you have EGFR plus X, it puts you at risk for squamous. So I think it's going to be a little bit more tricky to sort out just because the genomics of squamous cell lung cancer aren't fully sorted out.
And just to clarify one thing, a de novo cancer, that means the type of cancer that a person starts out with?
Yes, exactly. And I'm sorry I didn't clarify that. So I think there is de novo small cell lung cancer, and almost always that's kind of the typical, there is someone that has a heavy smoking history, which is almost all small cell lung cancers occur in people that have a heavy smoking history. But there are some EGFR mutant lung, I would say this is really rare, but there are EGFR mutant lung cancers that rarely present as small cell, that we find the EGFR mutation after we do genetic testing, but that is really rare. It really tends to happen after some amount of treatment.
Great, thank you for clarifying that as well. And a lot of times in the community, when transformation happens, there isn't a clear next step, as there is if you have progression and there's this trial or that trial. So there's been a lot of questions surrounding, should a patient look for a clinical trial after they've progressed? But even before that, if a patient is diagnosed and they do have both the RB1 loss and the TP53, is there something they should do with their initial treatment? Is there a trial they should look into for that? So they're looking at being both proactive in terms of, is there anything that can be done? And we also want to know what can be done, or if there are trials once we have progression.
Well, so that's a great question. So one of the questions is there anything that can be done proactively if is EGFR, RB1 and P53 mutations identified in the adenocarcinoma? And Helena is PI on a clinical trial right now that's looking to see if there's a way to use early small cell directed chemotherapy, whether you can add that to Osimertinib to lung adenocarcinoma, to see if you can treat any occult small cell transformation that hasn't been detected yet. But that's going on right now. I feel like Helena would be even better at talking.
I mean, well, Joe's doing the analysis, so I think it's a tag team. But I think I think that one thing that can be done is if there is a cancer if a person has a cancer that has that mutation, I think the idea of doing tumor tissue biopsies to look if there are signs of progression. If somebody gets a biopsy, the site of growing disease should always be biopsied. So sometimes, if there's growth, but there is a tumor that's more easily accessible, sometimes the biopsy doctor would prefer to do that. But I always am very clear about what I want biopsied. If it's this 1.5 centimeter lesion that's small and I know hard to get, but that's the one I want biopsy because that's new. So I think that's helpful because that's really capturing the disease that's progressing or resistant. And then because people that have that mutation, or lung cancers that have that mutation are the ones that tend to transform or might transform. Exactly like Joe said, I think we are hoping that by starting small cell chemotherapy earlier with osimertinib, that we might be able to try to target both, right? The EGFR mutant lung cancer that's still really sensitive to EGFR inhibition, but if there is a tiny subclone of the cancer that either has already transformed, but only over time will grow out, or if it's just the subclone that is predisposed to transform, where it might be adeno now, but that's the subclone that eventually will lead to transformation. If we can find a way to eradicate it prior to transformation, that's always helpful. And what Joe's doing is he in the lab, we're doing biopsies on patients on this study. And so we're trying to see if we can detect that subclone that might be predisposed to transformation or sort of en route to transformation, because the more we can study the genetics of what's happening, the biology of what's happening, the better we're going to be able to treat it, because we don't have any sense of kind of what are the other factors between adeno and small cell that make that transformation happen. So I hope we learn, I hope that we can help prevent transformation, but I hope that equally important, we learn about why it's happening in the first place.
Thank you. Thank you for explaining that. And it's really hopeful to hear that you are studying it right now and looking at who's at possible risk, you know, the people that have what type of subclones, because I think that, you know, we don't hear a lot about research that's going on right now, trying to understand the biology of it. So that's great. And so then once there's a progression and a person is diagnosed with a histological transformation, what should we do? Like, I think, what is there a specific trial we should be looking at? Are there specific questions we should be asking our doctors? Since it's not completely common, not every doctor is going to see it, right? So, you know, I guess we're looking for tools and we're looking for advice on how to handle the situation.
Yeah, I think it's important to do kind of a couple things concurrently. I think the EGFR resistors, I'm sure, is a good resource, because I think it's connecting patients with rare cancers together. And so I'm sure that there are likely resources or people who've been through transformation who might be a sounding board or an advice giver, or just can provide some kind of comfort or hope in that situation. So I think that would be important to do. I think, as Joe mentioned before, I think sometimes when this small cell transformation occurs, the small cell lung cancer can be more aggressive. So I also think it's not the time, I think, to shop around at, you know, or try to get several different opinions, you know, before you start treatment. I think that all of us that are kind of experts in EGFR mutant lung cancer would definitely treat this with chemotherapy. And so I think that just makes sense to do, and get control of the cancer. And then I think there's a point to stop and kind of think and maybe get those second opinions at that point. But because small cell lung cancers, as Joe said, are fast growing, they're actually really responsive to chemotherapy, where we see really nice shrinkage. And so I think starting on that, and it's usually a platinum plus etoposide. Those are the chemotherapies that are first line treatment for de novo small cells that also work really well for transformed small cells. I think one thing that is up for discussion and should be discussed with your oncologist is sometimes we give immunotherapy with chemotherapy for small cell lung cancer, but in this situation, it might be appropriate to continue EGFR directed treatment. So that would be one point to maybe specifically bring up with your oncologist is, would it make sense for me to continue Tagrisso and do the chemo, or do you think it would be better to add in the immunotherapy? And there's no right answer there, but it can be a little bit personalized, but that would be one thing. And then I think it is a really rare situation. So if there is the ability while you're getting chemotherapy, or maybe after you finish the chemotherapy during maintenance or observation, that might be a time, if you have the ability to get a second opinion, just so, you know, because it's a rare cancer, you want to sort of know what steps 2, 3, and 4 might be. And someone that's seen a lot of this might be able to help.
Are there any particularly promising trials out there right now for transformed small cell, or are people who develop transformed small cell, would they be eligible for any trial that, you know, is for people with de novo original small cell?
Ivy, I think that's a really important point. I think that, you know, we have a lot of small cell directed studies here at MSK and many, and of course at many other big academic centers. And almost all kind of de novo small cell studies do not exclude people with transformed small cell. So they're open to all cases of small cell lung cancer. And so I think it'd be important to ask your doctor about kind of the availability of small cell studies in general. I think one question that we don't know the answer to, but shouldn't preclude participation in these studies, is we don't know how small cell transformed and de novo small cells are different and alike. So we don't know if the same treatments will work for both. And I think that's part of the desire of trying to get sort of more registries or more kind of, you know, kind of come together to kind of better understand transformed small cells so we can get more information in that way. But yeah, no, I think that trying the de novo small cell studies would be good. But then I think, Joe, I don't know if you know of any transformed small cell directed studies, but I think that's an area where, you know, I have a few ideas in my head, and I think other folks are trying to design studies in that space too.
Yeah, kind of alluding to the question of how transformed small cell may be different from de novo small cell. The big caveat, first of all, is that there are no big trials that are dedicated to transform small cell that have been completed and can really recommend an optimal therapeutic regimen. But based on smaller studies, it has been shown that immunotherapies might have less response in transformed small cell compared to de novo small cell. But that being said, I think it's a discussion to see if immunotherapies could still be included, because immunotherapies in general have been shown that when they do work, they oftentimes have durable response rates. And the other thing to keep in mind is that there's still a lot of research going on, and there's some clinical trials, for example, one that's looking at adding different agents to immunotherapy to see if you can elicit a better response in transformed small cell. And so one example is durvalumab immunotherapy being combined with a PARP inhibitor, which has been shown. It's the early stages of the trial, but it was looking at EGFR mutant lung cancer, not specifically transformed small cell, but the transformed small cell patients that they did include did show, I think it was one patient showed a good response, and another with a partial response. So, but they're still looking at it, and I think there may be another trial that's specifically looking at transformed small cell, but looking at this particular regimen. So in short, I think that there's promise in trying to figure out how to really unlock the potential of immunotherapies in this disease.
That's great. Thank you. That's what we want to hear, is there's potential, there's study, there's research. So that's great to hear. I know we have to wrap up soon, but we have just a couple more questions. And one of them, they're both kind of more on a personal level. One of them is, you know, somebody said, you know, I have this disease, it has transformed to small cell, it's more aggressive, and it's really difficult to remain optimistic, and I'm very overwhelmed about possible side effects. Are there any tips, or are there any words of wisdom that you give your patients that, you know, in coping with a small cell transformation?
That's a tough question. I think that I would kind of put that in the same category as kind of talking to my patients about progression in general. I mean, there are so many ups and downs in the cancer journey where I think, things are well and going well. And then we get these setbacks where we have to sort of pivot and rethink. And so I think all of those are hard. And I always try to, sort of acknowledge those feelings, that those are appropriate, where you feel upset, you feel disappointed, and it's a hard situation and you need to sort of reframe. So I think all of those feelings are okay and normal. And then I think it's just about kind of empowering people and saying, but we know what this is, and we know what the right thing to treat it is. It is different. And we do kind of have to pivot and sort of focus on treating the cancer differently. But I think that there are options. I think, as we've mentioned a few times, the chemotherapy really works. And so I think it's a different thought process, because I think when we're treating EGFR mutant lung cancer, we're so focused on targeted therapies are the best. And so I think there's a frame shift there. But I think once people see those really good scans where we see really nice shrinkage, I think that can be encouraging. So I think, just realizing that it's a pivot and that, there is kind of feelings that are appropriate, but that there are options. And then I think focusing maybe on the clinical trials and all these people working really hard at figuring out, how to best treat this, that you're not alone. I think those are sort of the things I think about.
So I guess the last question is, we have a very motivated community that, we're all ready to go out there and advocate. Is there something we should be doing to advocate for more small cell transformation trials or histological transformation trials in general?
I think that, yes. I mean, I think we need to have a trial for sort of every different type of resistance mechanisms. And I definitely think small cell transformation is one where we don't have those studies and we need to find them. I think that sometimes I'm just thinking kind of spontaneously, I think that getting that second opinion and help or sort of figuring out a way to be part of a registry or kind of banding together, I think is helpful. And I think that once we find out that this isn't so rare, that it's happening and that there's enough people, I think to successfully do a clinical trial, I think that can be helpful. And so whether it's getting that second opinion and helping kind of contribute to the knowledge about this could be good. Joe, I don't know if you have other thoughts, but that's the first one that comes to my mind. But I think, definitely at MSK, we're seeing this frequently enough that, there's a lot of us working on research in this space.
Yeah, maybe I'll also just add another perspective from the preclinical, from the laboratory side. I think that's right. More research needs to be done to understand this disease. And maybe I'll also just share that small cell transformation, we've talked about how it happens in the lung space, but it can also happen in other cancers as well. One of the classic parallel stories is small cell transformation in prostate cancer as a mechanism of resistance to androgen inhibitors. And one of the interesting things is that there is some thought that different targets like EZH2 inhibitors, adding these can actually restore androgen sensitivity in this disease. And so I think it's still a little early to see if this same story can be replicated in small cell lung cancer, but I think advocating for more research in this space and really trying to make different connections between these different diseases may be another promising avenue as well. And hopefully that can then advance things and bring and move things to the clinical trial space as well.
I think that's a great point. Yeah.
Yeah, I think that, and the news of the DoD appropriations being $20 million is great for lung cancer in their congressionally directed medical research programs, but we need closer to 100 million to really get it going. And they're doing a lot of those basic science studies and translational studies. And so advocating even there for more money could bring in more proposals for research. So yeah, that's a great point and a sore spot, right?
Mm-hmm.
I also wanted to add that it's not only the EGFR community that's seeing this histological transformation. The ALK community is seeing some small cell transformation. The ROS1 community is as well. So, there's a possibility of us, joining together and having more power as, a larger combined group to advocate for more small cell lung cancer trials.
Yeah, and I think it's just different pieces of the puzzle. I loved what Joe said. I think, we can learn from the prostate cancer folks or breast cancer where we all see it from a slightly different perspective, but they can all, sort of get us closer to the answer. So that's a great point.
Yeah. Ivy, can you think of any other questions?
I think we've covered all the questions.
If for some reason we missed a question, please reach out. We can direct it to Dr. Yu and Dr. Chan and get an answer. But this has been great. Thank you both so much for taking the time, sharing your expertise, and for your passion and your compassion. And I just want to know, Dr. Yu, I know several times you corrected yourself when you said a patient progressed or a patient, you corrected yourself to when the cancer progressed. And that means more than you can ever know to patients. It puts the patient first, person first language. So that did not go unnoticed. Thank you very much.
I learned it from the best, from Jill and so, I think any way you guys can give us feedback, I think we all have the same goal, right? To figure out ways to treat cancer, cure cancer, and help people live longer and live better. So I think we're totally open to that feedback and just, working with you together as a team.
Thank you.
Thank you.
And we want to thank Blueprint Medicine again for sponsoring this webinar series. This is so helpful to our community, and we really, really appreciate it. And to our community, all of you who submitted questions, thank you for those questions. We need those questions to get these rich conversations going and to get answers. And so stay tuned for more webinars to come in the future. Happy New Year.
Happy New Year. Bye.
Happy New Year, guys.